Thank you very much, colleagues. I would like to thank Kenya Medical Association for giving me this opportunity today to give a talk on the role of imaging in the COVID-19 pandemic. My name is Dr. Mercy Nyanchama. I am a lecturer and I chair the Department of Radiology in Jomo Kenyatta University of Agriculture and Technology. And I am also a consultant radiologist at Kiambu Diagnostic Imaging Services Limited. With the COVID-19 pandemic which has taken place, we know that coronavirus disease is multisystemic, meaning it not only involves the chest, which is the commonest, but also involves other organs like your brain. The cases of infarcts also increase, renal. It's basically a multisystemic disease. And because of its wideness, we shall concentrate more in this discussing the chest manifestations and the issues surrounding imaging. So we'll start with one of the commonest imaging findings. This is a plain radiograph. This is one of the most baseline imaging modalities that are used. In this you expect ground glass opacities, opacification, which is band-like and sheet-like, and predominantly within the lower zones. You also get to see consolidation still within the middle and lower lung zones. It's very rare to get a pleural effusion, and by the time you're getting a pleural effusion, then you must be thinking of something else, or the severity of the illness is much, much more. Like this X-ray that we have in front of us, you can actually see some perihilar shadowing, but also ground glass opacification on the peripheries of the lung and the basal lower zones of the lung. This was a 54-year-old who presented, this was a local case, a 54-year-old who presented with difficulty in breathing and coughing for approximately 3 weeks. Now, according to studies that have been done, you will see the first study for about 64 patients. This is what helped us find rather globally that what were the imaging features of COVID-19 within the chest. So on the left, you see the number based on 64, and on the right, within the parentheses, you find the percentages. So for the initial 64 patients in this study, there were 31% had normal baseline chest radiographs, meaning they had symptoms, but the X-rays were normal. Of those, 69% were abnormal, and this is just on plain X-ray. The number of patients with normal baseline chest radiographs later became abnormal. So the timing of the study also determines the findings. So the severity is based on when did the patient come. Is it early on in the disease, or is it ultra early, or is it late when you already have moderate to severe disease, but also depending on the comorbidities of the patient. The things that were seen in this study were 47% had consolidation, 33% had ground glass opacities. In distribution, peripheral predominance was in 41%, while perihilar predominance is in 9%. So when you see perihilar predominance, then your mind has to start thinking, is it possible that it's a different kind of viral pneumonia? The other thing was that in 30%, they were neither peripheral nor perihilar. There were more in the right lung by 16%. The left lung had 14%, and they were bilateral in 50%. So in more often than not, you will have them being typically bilateral. There was lower zone predominance, and in 50% there was lower zone predominance. There was no predominance in 0, and 30% had no zonal predominance. Other features, only in 3% did you find pleural effusions, and there were no pulmonary nodules. So this gave basically radiographic features of COVID-19 within the chest. So this indicated the usefulness of the plain X-ray in the imaging and the management of COVID-19 disease. Now, at baseline, Chest radiography, we've already discussed that. You have consolidation at 47%, you have ground glass opacities at 33%, lower zone distribution at 50%, bilateral involvement at 50%, and this is what gave the typical findings. So the commonest, as we have explained, are bilateral, peripheral, and lower zone. Peak chest radiography severity score was 10 to 12 days. That's the time you'll find that the chest radiograph is the worst in terms of its appearance. And it also commensurated with the findings on CT. But you must remember that CT is much more sensitive than plain X-ray. So then came in the discussion on radiographic scoring. And in places that are resource limited, then there's a much higher usefulness of radiographic scoring, because maybe your access to CT may be low, and this doesn't mean that you cannot manage the disease. You still can, and you can grade the severity based on the radiograph. So radiographic scoring has been developed for scoring of disease within the lungs, and this is very important in resource-limited settings where you only have the X-ray available, or the patient is too ill and is within ICU and you have access to a portable radiograph. So the first one that was developed was radiographic assessment of lung edema score, which is based on the edema that you're seeing, and it's a score in each lung of 0 to 4, depending on the level of involvement, meaning 4 would be maximal in each lung, meaning a total score of 8 if you have maximal disease involvement. 0 would mean no involvement, 1, 25%, 2, 25 to 50%, 3, 50 to 75%, and 4, more than 75% involvement. And then you sum the scores in each lung to produce the final severity score. So a baseline chest radiograph sensitivity of 69% has been useful, especially in resource-limited settings, as I have said. Now recently, actually in December, the Brixia score came about, where the lung is divided into 3 zones, and each zone is scored from 0 to 3, and then this is total and it's scored 0 up to 18. And you can see it there where the lung is divided into 3 zones. Also in reporting, we divide the lung into upper, middle, and lower zones. And at the top, you can actually see, based on the severity, you can score it up to 3, and those are 6 zones. And that would mean, if you compare the image to the left and the image to the right, you can actually see the difference in scoring. So you have more ground glass opacification and increase in bronchovascular markings on the right, and so your scoring is dependent on the imaging features that you see. This is very useful in predicting disease outcomes, especially, as said, in resource-limited settings and the evaluation of disease evolution. The advantage of this scoring is that if one radiologist has seen it previously, you can compare a repeat image and the repeat score, even if it's a different observer. And then you can compare the disease progression or the disease regression. So it's very good in evaluating multiple images. Now, the advantages of X-ray. X-ray is more basic, and as you can see, the sensitivity is up to 69%. It is low in comparison to CT, but it does have its advantages. The first, it has a lower radiation risk. It's cheaper and more available. For example, you can see in our country, there is much more availability of an X-ray than the PCR test. So, evaluation of the disease, if you don't have availability to a PCR test, then you can start out with your X-ray. Logistically, it is easier, so patients in ICU or within the COVID wards, you can also use a portable machine and actually have the X-ray done at bedside. So it's very useful in patients with poor clinical conditions. Again, there's a long process of CT machine decontamination in between patients, and both CT and X-ray have low sensitivity in ultra-early disease. Therefore, X-ray is useful in mild disease. There is no point to expose your patient to high doses of radiation with CT when you can start off with an X-ray. Now, When we move to CT chest, okay, CT chest, the protocol for CT chest, of course, a CT chest is more sensitive than the X-ray, but the way the CT chest is done is also important. So in CT chest, you use a specific protocol. In this case, you use non-contrast chest CT with reconstructions at 0.625 to 1.5 millimeter slice thickness. The reason for this reconstruction is that you could use thin slices, but thin slices will increase the dose of radiation. The other thing, this is faster. You're dealing with patients who are sick, they are coughing, they're unable to breathe, so they're likely to give motion artifacts, which will make your CT be inaccurate. Now, if you do require to do a CT pulmonary angio where thromboembolism is suspected, a pulmonary embolus is expected, then you do a non-contrast study first, as iodinated contrast media may affect the interpretation of the ground glass opacities. Now, in this particular picture, you can see the difference between a normal CT chest and a COVID-19 chest CT. On the left, the lung is clear, the vascular markings are actually quite all right, and then compare it with the right. In the right, you start seeing ground glass opacification. That's what appears as haziness. You have interlobular septal thickening and intralobular septal thickening. In cases, in other cases, you actually have vascular dilatation within the focus of ground glass opacification. You also have other features like crazy paving, where you have ground glass opacification with septal thickening. All right, so the typical features on CT for pulmonary involvement of COVID-19, obligatory features are ground glass opacities with or without consolidation. And remember, consolidation tends to begin basally within the basal segments of the lung, of the lower lobes usually, but can also be the basal segments of the basal segments of the upper lobes. So including the features, you have ground glass regions. Confirmatory patterns are ground glass regions, sharp demarcation outlining the shape of the multiple adjacent secondary pulmonary lobules. And one typical characteristic is that the subpleural location of the ground glass opacification. And then thickened vessels, as mentioned before, within the parenchymal abnormalities. As we've mentioned, pleural effusions are rare. So with this, you have COVID-19 reporting and data system, and this is what you'll begin to see in your report. I will explain what it means. This is a standardized reporting system for patients with COVID-19 that was developed by the Dutch Radiological Society, and it was a way of predicting whether your PCR test would be positive. All right, when you see it there, it was based on the grading. 0 meant not interpretable, all the way up until 6. Okay, as we go ahead, I'll explain that CORADS 0, the scans are incomplete or of insufficient quality. Basically, you cannot make a decision. In CORADS 1, you have normal. It's either normal or whatever disease is within the CT, it's of non-infectious origin. So you can have a patient with difficulty in breathing and cough, but it turns out that it's mild or severe emphysema. You may find periphyseal nodules, lung tumors, and fibrosis. In CORADS 2, it is an infection, yes, but has a low level of suspicion for COVID-19 pulmonary involvement. The examples would be bronchitis, infectious bronchiolitis, bronchopneumonia, lobar pneumonia, and pulmonary abscesses, amongst others. And what you look at are things like centrilobular nodular pattern, lobar or segmental consolidation, and lung cavitation. All right, so that's where your TBs are going to fall in, where you're going to get the tree in bud, and you know that geographically, our geography, Kenya, that is, we also have a high incidence of TB. So not every cough is COVID, and there'll be times you'll have patients who have both COVID and have TB. In CORADS 3, these are equivocal findings for pulmonary involvement based on the features that can also be found in viral pneumonias. Remember, the first differential diagnosis for COVID-19 is actually other viral pneumonias. Cardiogenic edema is another cause. In this case, you're seeing features that can also be seen amongst the other diseases. So you have perihilar ground glass opacities, homogeneous extensive ground glass opacities with or without sparing of some secondary pulmonary lobules. You'll still have ground glass with smooth interlobular septal thickening with or without pleural effusions in the absence of other typical CT findings. Remember, in COVID-19, the apices of the lungs and the apical segments of the lungs are typically spared. CORADS 3, ground glass opacities that are not centrilobular or not located close to the visceral pleura. So in CORADS 4, you have a high level of suspicion for COVID-19, but also overlap with other viral pneumonias. In CORADS 5, you have a very high level of suspicion for pulmonary involvement by COVID-19 based on typical CT findings. And in this case, you can start treatment as you plan for a PCR test. In CORADS 6, you have a proven COVID-19 by RT-PCR positive, which means that this is reverse transcriptase PCR positive, which means that for sure this is a definitive diagnosis of COVID-19. But remember, you're going to have some cases where the PCR is negative based on how it was sampled, yet the CT has typical findings of COVID-19. In other cases, you might have a normal CT, but your PCR is positive for COVID-19. In this case, the study that was done for this, you can see the overlap and the diagnostic performance of CORADS. In the red is the positivity of PCR in the score. Yellow is PCR negative, and green is PCR negative and diagnosis negative. If you notice on the lower line of the bar graph, you find that as you go towards CORADS 5, your positivity rate gets to 93%. So once you have a CORADS 5 on imaging, then it means that even if you were to do your PCR score, chances are your PCR is going to be positive. So once you get to CORADS 4, CORADS 5, you're already thinking, can we treat, whether or not you have your PCR available. And we must remember that in our part of the world, PCR is not that easily available, and the cost is also prohibitive. Now, CORADS grading, therefore, determines the likelihood of positive reverse transcriptase PCR test and a clinical diagnosis of COVID-19. Now, this is a patient local case where you can see from the top, you can actually see the ground glass opacification, which is both perihilar and peripheral. Then had a CT chest done, and you can see the lung window where you're getting ground glass opacification. You're already beginning to get interstitial thickening. You're getting intralobular and interlobular septal thickening, which gives you the crazy paving. Again, if you look, you're beginning to get subpleural consolidation. These were the lower lobes of the lungs. The other thing you can note is that there were motion artifacts. Remember, these patients are not able to breathe well. They have difficulty in breathing, and they also cough during the procedure. On the right, the extreme right, the bottom right corner, you can actually see that that is a mediastinal window, and you can see how not as helpful it is in the evaluation of the disease. Remember, in COVID-19, you have very minimal mediastinal involvement unless you're having cardiac involvement, where CT then would not be your option. So this was follow-up of a patient who had a chest X-ray done, and then the CT done for scoring and also for management. Now, CT involvement score, I'll bring it in as this severity score. You will understand on the report. It tells you the severity of the lung involved on the CT, and it correlates with the severity of the disease. So the first thing is visual assessment, where the radiologist will tell you, all right, it appears that 25% of the lung has been involved. Remember, with COVID is a pandemic that is evolving. So we are all learning as we go. So for the CT severity score, this tells you the score is not based on just visual assessment, but each lobe of the lung is scored by percentage, and then all of them are added up. And remember, you have 5 lobes of the lung. Maximal involvement is 0 for one lobe. 5 is maximal involvement. So the range is from 0 to 25. So if you have less than 5%, no involvement will be 0. Less than 5% will be 1. 5 to 25%, 2. 26 to 49%, 3. 50 to 75%, 4. And more than 75, 5. So if you have a score of upwards towards 25, then you know that your severity is quite a lot, and this is a prognostic indicator, meaning the higher you go towards 25, that means more likely that disease outcomes will not be that great. All right, so Kenya Association of Radiologists have come up with national guidelines for our geography. Okay, so there are other parts of the world where this disease has hit, but we also have our national guidelines, and we do thank them for developing this. So the main thing is that you require confirmation with a viral test, even if the radiological findings are suggestive of COVID-19 on chest X-ray or CT. That means once you get the findings, then the ideal is if you could get reverse transcriptase PCR, a PCR test available to confirm it. So imaging will not be confirmatory for you, but it will guide you. It's useful for classification of disease severity and assessment of the disease progression. So of course, you'll be able to follow up the patient from day one, all right? Generally, the findings on chest imaging are not specific. As we have said, with CORADS 3, they include influenza, SARS, and MERS, other viral pneumonias. And for us as radiologists, it's the ability to familiarize ourselves with the CT appearances of COVID-19. If features are highly suggestive in COVID-19 positivity, CT chest and CT abdomen, lung bases, then the referring clinician should be notified to test for COVID-19. Patient referral for potential isolation or treatment is considered. This brings me to the point of incidental findings. All right? In incidental findings, you find that a patient was coming for a CT abdomen, and you happen to spot a focus of ground glass opacification within the chest. All right? That means the patient is probably asymptomatic, or they were having a disease that has recovered. A patient could be coming for a shoulder radiograph, a shoulder joint radiograph, or a shoulder joint chest CT. And you just happen to see the lung, and you can see that this patient has COVID-19. And that means despite them coming for a shoulder X-ray, perhaps for dislocation or a fracture or a tumor, then you realize, oh, this is actually a COVID positive patient. It's just that they were not symptomatic, or it's the early stages of the disease, or it's the resolving stages of disease that did not present, or presented but was not reported. So that's very important in our setup. because then it affects infection control within the department, because then you have the risk to other patients and other staff, because you will probably not have treated them as a COVID-19 patient. All right, so this was a statement by the Kenya Association of Radiologists. Now, before we finish up with CT, we know that in COVID-19, coronavirus disease, there's a thromboembolism that happens. There's a proneness to coagulation, both within the brain and pulmonary arteries. So these are people who are likely to present with pulmonary embolism, either as a first presentation or superimposed on the disease as the disease becomes more severe. So there is a procoagulant state, and patients with severe disease are recumbent. Remember, they are also not mobile. A lot of them are not mobile, so they are likely to also develop thrombi, and most have comorbidities that predispose them to a greater risk of thromboembolism. So there's a disease itself, there's a fact that the patient is not moving, and the other thing is that they also have other conditions within them that cause a greater risk. So if you're looking for an acute pulmonary embolus, then you send the patient for a CT pulmonary angiogram. And it is limited to the evaluation of moderate to severe disease. There is no justification of the routine use of CTPA in the evaluation of patients with COVID-19. There have been cases of acute pulmonary embolism in non-hospitalized patients presenting with acute chest pain and difficulty in breathing, sent for CTPA. Lung findings are similar, they don't change. The risks that you have are contrast risks. We know that the risk in CT pulmonary angiogram are higher of contrast nephropathy, and the patients with these comorbidities are also the same comorbidities that predispose you to contrast nephropathy, your diabetes, your hypertension, your tumors. All right? Remember the predominant patient profile for severe disease for COVID-19. All right? So there is no diagnostic benefit to perform CTPA examination on initial presentation, and you must do your D-dimer values. And remember, D-dimers are elevated both in COVID-19 and in pulmonary embolism. So, of course, studies have been shown where there is a threshold between the D-dimer level for COVID-19 disease and the D-dimer level of COVID-19 disease complicated with pulmonary embolism or thromboembolic infarct. All right? So in this case, you're able to see that you have consolidation, and you can see the consolidation is predominantly within the posterior segments of the lung, which is quite typical. This is a CT pulmonary angiogram, and you can see there that's an artery that has a clot within it. All right? So as the clinical condition deteriorates or gets more severe, you need to consider sending for a CT pulmonary angiogram to exclude whether this patient has a superimposed pulmonary embolus. The advantage of CT is that it has high sensitivity, it is fast, it has a reduced waiting time. So of course, remember your PCR test is going to, in the fastest place, you'll probably get it after 24 hours. In other places, you'll get it after 72 hours. In other areas, you might not get it at all. So CT does have its advantages. The other thing, it has an ability to grade disease severity and to determine prognosis. We have discussed severity score, and the more severe the score, the more likely the prognosis is dire. So the risks of CT, remember you have lack of resources, the PPEs, personal protective equipment. The more you take for CT for COVID-19, the more protective equipment you use, all right? And if you have limited resources like in a pandemic, then you don't want to waste them. The other thing is the way the CT is done, you have an increased risk of viral transmission to the staff, the patients, the caregivers, and other negative patients within the department. The third and most important risk is exposure to ionizing radiation, which we know is linked to malignancies. Now, ultrasound. Ultrasound is actually a very useful, and it's also very available. It's a very useful study, but I'll draw attention to point of care ultrasound. This is where the patient is sick, bedside, and you actually get to examine the lung. We know that ultrasound is produced by the use of sound waves, and so there's no ionizing radiation. So you actually have got no radiation risk. In ultrasound, we look at B lines, which are reverberations of the ultrasound beam between slightly decreased alveolar air and increased interstitial fluids. Basically, in consolidation, what happens? You have inflammatory fluid, and in a well-aerated lung, you have air. Air is echogenic, but where you have fluid, then it becomes hypoechoic. It's reduced because fluid has lower sound, all right? So it will be hypoechoic, all right? So it will not reflect sound as much as the air will. So what will happen is that the places where there is more inflammatory fluid, they will look darker, which is also called hypoechoic. Now, the B lines are visualized as multiple vertical echogenic reverberation artifacts extending from the lung surface. Your differential diagnosis for B lines, meaning that every time you see B lines, it's not necessarily COVID. You have cardiogenic edema, ARDS, pulmonary fibrosis, and other viral pneumonias. Another thing we see are thickened pleural lines, which means it indicates pulmonary fibrosis and a longer disease duration. It indicates a longer disease duration, meaning the longer you've had COVID, the more likely you'll have a thickened pleural line. The third thing is pulmonary consolidation, and this is seen in severe and critical forms of COVID-19, where you have tissue-like hypoechoic regions, as I have mentioned earlier, which reflect highly reduced airflow and increased quantity of inflammatory cellular exudates. So in this case, as you can see, there's a healthy 32-year-old, and on the left and on the right, you can actually see the reverberation artifacts that tell you that it's not everything is right, all right? So you can pick up the B lines on the right image. Now, again, this was a 82-year-old with cough, dyspnea, and fever for 10 days. The PCR was positive, and you can also see the reverberation artifacts. You can see also the reduced echogenicity of the lung because of consolidation. And on the CT done, you have your thickened pleural line at the top, the small arrowheads. And as you can see, on the CT at the bottom right-hand corner, you can actually see that there is consolidation at the back. You're beginning to get linear fibrosis at the end, especially on the left lung. You have compensatory hyperinflation on the left. On the right, there's reduced lung volume. Okay, on the right, you have reduced lung volume, and you can actually see compensatory hyperinflation. So what is the utility of ultrasound? Number one, ultrasound can grade the severity for you. That's one. So it can tell you which patients with COVID-19 have severe and critical forms of the disease. The ultrasound is useful in monitoring. So it means that if we do an ultrasound today, we can also repeat it. Important situations where chest CT is not available, such as in isolation wards and ICUs. And it's also good in infection control and reduction in radiation risk in patient evaluation. So we must discuss radiation safety. Of course, ultrasound is great, but if you were to choose between the CT and the X-ray, of course, then you have a difference in each of them. And we have discussed the usefulness, but we must discuss radiation safety. So the use of imaging should be judicious, meaning you must determine, is it truly necessary? So in mild disease, is it necessary to do the imaging? If you have access to a PCR, then have the PCR test done. because remember, you have an increased radiation risk in the utilization of X-ray and CT with eventual development of malignancies associated with radiation exposure. If you look at this from the American College of Radiology, you can see the comparison. With a CT chest, you have 7 millisieverts, whereas a chest X-ray, which also exposes you to radiation, is 0.1. So by the time you're doing a CT chest, then you have to make judgment that is it moderate or severe disease, and what is the added value. Of course, there have been arguments towards it, with China believing something different, with the Americans believing something different, but always make a judicial decision based on the facilities that you have and the location that you have in the country. So we must talk about infection control in radiology departments, because imaging is very central in the management of COVID-19 disease. Then that means that the X-ray department, the radiology department, is central for disease. So is central for disease spread, or there has to be a lot of decontamination. You have to be keen with how to control infection in radiology departments should you run one, or if it is in your facility. Yeah. So remember that all radiation department reception staff should ask standardized questions which require answers prior to the patient service provision. So you want to know, is this a patient who's coming in, a normal patient for an obstetric ultrasound, or is it a patient who's coming with other symptoms that are more similar to COVID-19, and how do we treat them? Are they PCR positive patients? Are they patients with fever, with severe acute respiratory illness? Early on in the pandemic, we used to ask for history of travel. Right now, we don't, as mentioned there, because we are already at the level of disease community spread. So this was at the beginning, but now 98% of the cases are as a result of a community spread. The examinations are to be protocoled by the radiologist to determine the suitability of the study and the likelihood of unnecessary transmission risk. Now, that's at the beginning for the patient. For the members of staff, they must have hand hygiene products, frequent hand washing, and better utilization of work shifts. Now, it depends on the procedure that's being done. If it's a non-aerosol generating procedure, then the kind of personal protective equipment is different. If it's aerosol generating procedures, of course, then you need higher end personal protective equipment. If it's the machinery, if the resources allow, you can have dedicated machines. If not, then you must space the patients in between procedures for at least 1 hour and clean and disinfect the equipment in between procedures. All right? Now, what we are concerned with, yes, we have had COVID-19, but unfortunately, it's not over, because we're beginning to see cases of what I call long COVID, where the patient has had COVID, but also has persistent symptoms after 3 months, which are almost similar to COVID. A lot of them are presenting with continuous dyspnea or exertional dyspnea and features of small airway disease. This is lung fibrosis, and what you look at within the lungs, and you can see those images that are there, there's a difference in attenuation. You have multiple foci of low attenuation, meaning you have airway obstruction and airway trapping based on small airways having been obstructed. So these are patients who eventually might actually have, we've had patients being retired on medical grounds because after they get COVID-19, they're not able to function. They are either continuously dyspneic, or they climb the stairs, they get tired, they're dyspneic again, and so there's a role of repeat imaging. Okay, usually after 2 months, you expect that the imaging findings would be clearer, or residual lung fibrosis. But now we are seeing features of a longer term disability. In BNC, you can see those are expiratory views, and you can tell that there is reduced attenuation because of air trapping. All right. Now, again, you look at things like loss of lung attenuation, loss of lung architecture. In that one, you can actually see pneumatocysts developing there, and this is somebody who had long COVID, who had a previous history of COVID. Now, it's funny, with the studies that we've seen, you find that just because someone had mild symptoms in the initial disease does not mean their post-COVID symptoms will be better. Sometimes someone had mild symptoms, a patient has mild symptoms, but then later on has actually seriously impacting presentation of the disease later. While you have a patient who has severe symptoms and severe disease of COVID-19, but then returns to normal lung function. What we would say is that with this is that one thing you have to determine is that did this patient have a normal baseline CT, meaning were they normal before they got COVID-19, or are this as a result of a previous illness with a superimposed COVID. So it's good to know, did this patient have a baseline CT that was normal, or whatever it was, what are the added features that we're getting because of exposure to COVID-19. So in summary, there was a Fleischner Society, which is a multidisciplinary global society on thoracic imaging, which had a consensus statement on 7th of April 2020. We've had statements from the CDC, we've had statements from the Royal College of Radiologists. Of course, this is a disease that, and as I've mentioned, Kenya Association of Radiologists. We've had some from the Dutch Radiological Society, others from Italy. And of course, this is a disease that is evolving, and we have to consider that the geographical facilities, of course, and approach to disease. But the main summary is that imaging is not indicated in patients with suspected COVID-19 and mild clinical features unless they are at risk for disease progression. Imaging is indicated in a patient with COVID-19 and worsening respiratory status. In a resource-constrained environment, imaging is indicated for medical triage of patients with suspected COVID-19 who present with moderate to severe clinical features and a high pretest probability of disease. So what do we mean? We mean that what does this mean? It means that if the symptoms are mild, there may not necessarily be a reason for imaging. However, if the disease is moderate to severe or the patient is worsening, then is when you can utilize imaging. In other places where imaging has been used to triage, it's usually if you do not have availability to PCR, so you have to factor in, is the PCR test available, number one. Number two, what is the clinical status of the patient, and is it worsening, all right, or is it stable? Okay, so you have to consider this as you choose and as you go ahead. Is imaging useful? Yes, very useful, as we have mentioned. Those are my references. I would like to acknowledge Kenya Medical Association. Thank you very much for allowing me this platform. For giving me this platform, Kenya Association of Radiologists, who have also been very useful in coming up with our national guidelines, Jomo Kenyatta, University of Agriculture and Technology, where I work, and Kiambu Diagnostic Imaging Services Limited for their contribution to some of the images. Thank you very much.